Guillermo Farini, a parent. He was one of the first Westerners to cross and to get into the Kalahari Desert. And he apparently saw many things, and he wrote a book about that. And that myth was created by him in the 19th century. And then 1932, actually, it was so stimulating story that in 1932 alone, 25 expeditions were launched to find the lost city of the Kalahari. Obviously, until now, it's still a myth and a legend. But tonight, it's not a myth and a legend. Tonight, you will hear true, hard facts from very well qualified and experienced colleagues. So, without further ado, I'll leave it in the experienced hands of Jim from now on.
Are we live? It seems like we're live.
Okay.
Yeah.
Good evening, everyone. Colleagues here in the room in front of me, and colleagues sitting remotely. Apologies for the late start. We've had to balance. I didn't realize it was so difficult. Now I know to balance the needs of a live room and the needs of a remote audience. So I'm going to adapt the talk to fit into the more or less the time slot that people have, I'm sure, allocated to hear us. That will mean that in some cases I'm going to say I'm not going to cover this now. However, I make the offer that anybody who's particularly interested in all the details or some of the details that I don't cover, I'm very happy to make the slideshow available. So you can go back and check what did we miss there. I'm not sure it missed that much. I'm going to talk tonight about tuberculosis as an occupational disease. And the minute you start talking about occupational disease, you're in problematic territory. Now why is that? Why is that? First of all, an occupational disease is not a medical diagnosis. It's actually what's been described by an historian as negotiated disease. Society, members of society argue among themselves, the industry, the employers, the unions, NGOs, the workers, about what is occupational. And that is particularly the case where you have multifactorial diseases. And in the case of tonight's disease, tuberculosis, which is clearly also a community disease. So how can a community disease that anybody can get be an occupational disease? And that affects how we manage it. And the reason that there's so much controversy is that the minute you call a disease occupational, somebody's got to pay for it. They have to pay for the prevention, and that would be the employer. There is a legal structure which requires the workplace to be inspected. So there's a burden on the government. There's a treatment burden. Who treats an occupational disease as opposed to a community disease? Who pays for it? And compensation, which is a permanently controversial issue. So that's really shaped the way that we think about TB, or TB is thought about historically, for the two groups I'm going to talk about tonight. The two groups, firstly, is us. The first group is us, healthcare workers, and the second group are miners, and particularly tonight, gold miners in the South African context. So I'm going to start with a case study because that illustrates a lot of the problems and issues that some of which we're going to take up today. So sometimes you hear people saying, well, TB it's a nasty disease, but it's treatable. You get your 6 months of treatment, you're back at work after a month. The treatment's nice, but essentially it's treatable. For many people who get TB, it's treatable, yes, but they never recover. And I'm going to give you one example. So this is a 58-year-old negative, HIV negative, former dialysis nurse, worked in a hospital, diagnosed with MDR. In the course of taking a history, it transpired. She worked in a crowded, non-ventilated space, the dialysis room. There were 14 dialysis machines in the room. The air conditioner was frequently dysfunctional. There was no screening of renal patients coming in for TB. She was never provided with a respirator, that is an N95 respirator, and there was no communication or training of her as a dialysis nurse in infection control. She was on treatment for 16 months. She underwent a surgical lobectomy to remove part of her lung. She suffered hearing loss and peripheral neuropathy due to the treatment, the drugs. She suffered depression and severe fatigue, leading to her medical retirement, premature medical retirement. She didn't get her rights. The case was never reported under the Compensation Act. This would have been outside the mines, obviously, COIDA. And there was no occupational health management of the case. No one came around and said, why did this nurse get TB? And that is the actual fate, not necessarily as severely medical, of many healthcare workers with TB. No one comes around. Okay, so I'm just going to spend a bit of time on this framework, because I don't know how many people in this room, and of course I'm not going to find out how many people watching, actually run or managers, clinician managers of a practice with staff of a facility, an outpatient center, a hospital. But if you are, then you need to take a programmatic approach. And this provides a type of programmatic approach, and it's a public health approach. This is the pathway of TB. In the beginning, we are unexposed to TB. Some of us will have been exposed in childhood. If we're exposed and our immune system can't clear the bacillus, we become latently infected. As I say, some are latently infected from childhood, but many healthcare workers get infected at work. The mitigation and the necessary steps are in the right-hand column. Our first job is to prevent transmission. Very difficult. We've got to prevent healthcare workers from becoming infected. Secondly, once they become infected, we do have an option, and that is to provide them with preventive treatment. In this case, we'll talk briefly about it, INH or rifampicin or whatever regimen is used for what used to be called INH chemoprophylaxis. Today it's called TPT. That's an option because it's not widely used in our setting. If the immune system is incapable of maintaining the TB in a latent state, they become infected. Now they have to be treated, otherwise they're going to get very sick. So the medical system now springs into action. If we want to pick them up early, we need to screen, and I will be talking about screening a bit tonight. They have to get proper medical, I should say we need proper medical care to ensure we finish our treatment. If we're multi-drug infected, we need to get prolonged and different treatment. And we don't want to end up like the dialysis nurse. That's really at every step along the way, each step of that each action that we need to take is designed to prevent the next step. Otherwise, we end up with an impaired or disabled healthcare worker who can or may return to work at some stage and requires disability management and compensation. So if you're a manager, that should actually be your picture. Not, unfortunately, handing out masks. So the first response to the COVID epidemic, and it's a different epidemic, but I mention it because it's like the sort of elephant in the room that shrunk but is waiting to come in the other door. Masks. Everybody must mask up, mask up. There may have been good reasons for that because it took time for systems to get into place, but it's still the case for TB. You ask people in responsible positions, they say we give masks. People don't want to wear them. Staff don't want to wear them. Okay. Just, is TB actually, do we have, what sort of evidence do we have that TB is an occupational disease? We need to look at the epidemiology. So surveys of healthcare workers find that about half of us to 80%, depends where you go, are latent TB positive. So either we have a positive PPD or, sorry, Claudia, are you following me? Next slide. Sorry, no. Is Claudia, are you following me? Okay, thank you. We are positive, either in blood test, the skin test, but more important is if you took a group of healthcare workers who were PPD negative, who didn't have latent infection, you tested them at baseline, and you tested them a year later after their work in the hospital or in the community centers, what percentage will convert? And it's really the conversion rate that tells us what's happening. There's only been a couple of studies. A study done by our colleague Shahida Adams in the Western Cape found that depending which test you use, because unfortunately the skin and the blood tests give you different results, between 30 and 38% of the staff in her study converted in the course of the occupation. Johannesburg, I think it was the one of the big teaching hospitals, 29% of the staff converted, including medical students. The conversion rate among medical students was lower than for staff. So there's no doubt that people are getting infected at work. Next slide. So again, depending where you look, the rate of TB in healthcare workers is sometimes that of the general population, but in other cases, 2 or 3 times that of the general population. The one study that's looked at multi-drug resistance in the heart, admittedly, in the heart of the HIV epidemic in KwaZulu-Natal, found that healthcare staff were 5 times more likely to be multi-drug resistant. And as we know, in the one hospital, Church of Scotland, was it? In KwaZulu-Natal, there were a number of deaths among staff from the XDR epidemic. Treatment outcomes. Were healthcare professionals good patients? Are they likely to complete their treatment? In fact, in a cohort study in KwaZulu-Natal, they found of all the health professionals, many nursing staff, but also healthcare workers, I should say, not just professionals, people who worked in healthcare staff, that's the clerical and kitchen and so on, 41% did not take their treatment as required. There were 9 deaths. So it's a problem. Okay. What has been, next slide, what has been the global response? Well, for 50 years, we've used the American and WHO model. And that says there are three types of things you need to do. There's administrative, environmental, and respiratory protection to protect staff. So the administrative are the things that we are actually required to do as healthcare workers and professionals in the medical settings, and that is to make sure that people come in, they're cough triaged, they don't sit with other patients. If you suspect TB, they need to be segregated. If they have TB, they need to be in an isolation section. Staff need to be trained. PPE, they'll come to that. And all the things you need to do to try and limit the amount of the number of open TB cases in the hospital and the healthcare setting to whom staff have contact or exposure. Okay. Secondly, there's environmental. Now we're talking about spaces. You have to have the spaces. You have to be able to isolate people. You need those spaces available. And this is not always the case, particularly if there are a lot of TB patients. You need air you need ventilation. Maybe the windows are open. Maybe you have access to air conditioning. Or you might put up some technology like ultraviolet lights to irradiate the bacillus. Now that's usually assigned to engineers or other public works, whoever comes in and does that, essentially as a parallel structure within the hospital, and often doesn't work well. And then underlying it, of course, is budget. And thirdly, and you notice in this slide, the third line of defense, which is in occupational health, is the last line of defense. You ask people to put on masks. This is for tuberculosis or respirators. Next slide, please. So why is it the story of protecting healthcare workers from TB in this country, but in many countries, is not a particularly happy one. And particularly in the public sector, which is always has so many different competing demands on a shrinking budget. First of all, who is accountable? As someone has said, it's everybody. If something is everybody's business, if we all have to protect ourselves and the staff we work with, it's nobody's business. The TB protection seldom gets priority. Why is that? Because many healthcare workers do not report their TB to management. Doctors in particular do not want to, they regard as private business and they go to private doctors. But even among nursing staff and other categories of staff who do not have access to private medical care, they would prefer to be treated elsewhere and for their disease not to be known to the management. Why is that? It's because they're worried about their jobs. And it carries a stigma. To be infected with TB, to suffer from active TB, as we've heard from many accounts from staff, and there may be people in this room, there is a stigma attached to being HIV, terrible stigma. Some of it attaches to TB. And even with COVID now, we're hearing stories. An infectious person is a contagious person and therefore to be avoided. Staff and budget, I don't have to tell this audience the problem of having to put in place any program which requires an extra staff member or extra equipment. Space is short, ventilation is usually, even if it starts off well, and this has been seen in many occupational settings elsewhere, you start off with a well-ventilated space. Within a few years, it's got partitions and offices everywhere. Windows are closed up. Often the staff close the window because it's cold. Inadequate maintenance, the lights that were put in at considerable expense, the ultraviolet lights, after a few years, people came, they didn't realize they weren't working. The light was on, but they weren't doing their job. And PPE is often inadequate or inappropriately used. The wrong people wearing it. People who should be wearing it aren't, and the people who don't really need it are wearing it. I'm not going to, next slide, please. I'm just putting this, you don't try and read this. You'll have to have very good eyes. But I just want to make a point about now moving into the future and the type of thing that I and some colleagues have been thinking about. The Council for Scientific and Industrial Research, the CSIR, engineers and architects who work in Pretoria, and they have come up with, I think, is a much better model for trying to prevent transmission in healthcare spaces, and it's based on air quality maintenance. Air quality maintenance. And what is used to measure the air quality is not measuring the mycobacteria in the air, which is extremely difficult, but measuring carbon dioxide. Carbon dioxide in the air. And they've used that for the COVID model. And the ultimate idea is to make sure that the air quality and the carbon dioxide level is low, which is an indicator of sufficient air quality to be able to dilute out infectious hazards. Because you can't have one model for TB, another model for coida, another model for influenza. But what the air model also has to take into account is how the healthcare is structured. How many patients come in per day? Where do they sit? How hot is it in the room? What is the humidity in the room? What sort of exposure does staff have? Have the staff been educated about the TB? Have they been vaccinated in the case of COVID? That wouldn't apply to TB. What is the ventilation? All these things need to be taken into account, and that's really the problem facing management, not having three different headings. I take responsibility for this. You take, I do the staff, you do the air conditioning, and then make sure procurement has enough masks provided. The manager's responsibility to think about all these things, and some of them come up. Crowding is a inevitable consequence of the healthcare system we have. And as long as people are crowded to spaces in which the mycobacteria can move freely around and infect the people, then the levels among patients will, transmission will take place among patients and staff will be exposed. So it brings it all together, but I'm not going to labor that. Again, if you're interested, and I think this is something of the future, there's a problem with air quality monitoring. Actually, I just want to say one more thing about it. The problem with air quality monitoring is asking a question you don't want the answer to. So, for example, they've tried putting carbon dioxide monitors. The CSR has worked in some settings where they put carbon dioxide monitors and an alarm rings if the level gets too high. So we were sitting here, it was very crowded, and it was a cold day, the doors were closed, the windows were closed. The alarm rings. And what they found is after a while, the management was all over the place trying to improve air quality. No. The staff switched off the alarms because interfering with daily practice. In fact, there was very little happening in response. So it's really, there's no point in monitoring air quality if you're not going to do anything about air quality. Next slide, please.
Next slide.
Okay, next slide. Sorry. Yeah. Okay.
Next.
Yeah, next slide. What's the time?
13:46.
So how long have I been talking?
about.
Okay.
20
20 minutes. Okay. So I can finish off this section. Sorry, I have to adapt now. I'm going to have to find out. Okay, I'm going to finish off here. I said I was going to talk about prevention in the form of air quality and transmission reduction, screening. So screening is another of those thorny issues. Everybody wants it, but nobody does it. And when it happens, it's a burden. So the South African guidelines for protection of TB among staff require annual screening. Now, when I started medicine, we started off, we had a baseline screen, but not annual. This was when I trained at Groote Hospital. And after a while, it fell out of favor. I don't know if is anybody in the room here that I can ask undergone regular screening for tuberculosis in the course of your career? No? Ever had an X-ray as a staff member? One, when you started. No, I'm not talking about going to be worried about that you are getting TB. By screening, I mean you were invited to come and have an X-ray. Okay? Yeah, you had one. Yeah. So it's uncommon today. Did you know that the TB guidelines, the TB guidelines require all of us, or particularly people involved in, that wouldn't apply to me, in clinical practice, where there are TB patients, to be screened annually? We didn't. Okay. So just to make the point about screening, when a patient, if a nurse or a medical healthcare worker comes and says you're worried about coughing, that's not screening. You're investigating for TB. Screening is asymptomatic, inviting people who don't have symptoms, not inviting them in an occupational health setting, requiring them to be screened. So that's entering difficult legal and labor relations territory, but that's what it is. Because if it's voluntary, who comes? As they have campaigns from time to time to our hospital. They've got to sign, come and be tested for TB. Who comes? Mainly what we call the worried well. And who doesn't come? The people who really worried they have TB, because denial is also, I talked earlier on about people who don't want to report they have TB. They wanted to be offline, off screen. Us, including our colleagues, and I'm sure we all know stories of our own colleagues who have denied to themselves that they're getting sick. And by the time they go for the examination of their breast lump, or in this case, they're coughing, they have advanced disease. The other problem about screening is that 50% of tuberculosis in South Africa, as we know from recent prevalence surveys, is asymptomatic. Now that struck me as quite extraordinary. 50% of the people picked up community surveys are asymptomatic. Okay, so that's so much for. Yeah, next slide, please. Sorry, it's still me. The other thing about TB, who's at risk? It's not the people in the TB wards because everybody's on treatment. It's everybody. Everybody who's seeing patients coming in, taking their clerical details, transporting them, feeding them. And the people who actually are probably least at risk, as happened in COVID, people who had most exposure to COVID in the ICU had very low rates. So what is required really is some sort of risk stratification. Practically, it has to be the people who are at highest exposure in the areas. Now, I don't know, I should have acquired before I came, how much TB that you have in your hospitals and in your clinics and so obviously that is an important factor. That's the basis public health approach. And I just want to end off something we're doing research on, is that in getting a computer to read the X-rays, computer assisted diagnosis. And what it does is now with pretty good accuracy, on the left side, you have the X-ray, the input chest X-ray. And on the right, you have something called texture analysis. And computers now are very good at identifying areas of abnormality, but more specifically areas which conform to what we would recognize as possible TB. You can see that there. And the more likely the TB, the higher the score. Okay, so I'm going to end the part of the talk on healthcare workers there. And go on. Only 20 minutes to go. Yeah? Just 7. No, I must push on. I need that extra 20. So
to 1915. 25.
Yeah.
25. That's fine.
Okay, so we now move on to miners. TB is an occupational disease among miners. Okay, so the focus tonight is going to be on miners with silicosis, which is probably not, it's not the problem in this area. But some of you may occasionally see miners with silicosis, and they will be almost certainly gold miners or have worked as a gold miner at some stage of their life because they have very high exposure to silica. So tuberculosis and silicosis are very, very close relatives. In fact, at the late 19th century, the early 20th century, there was only one disease. It was called miners' phthisis. It's a combination of dust and the recently discovered, remember Koch, 1870s, discovered the tubercle bacillus. But the disease has been known for centuries. And it was only in the first part of the 20th century that the two diseases were separated. And it was only in 1930 at a conference in Johannesburg that the scientists agreed you could get sick from silicosis without TB. So they often came together, but they now said we have two diseases. We have silicosis, which is dust, and we have tuberculosis, which is the disease we know, but they often come together. South Africa was, because of the gold mining industry and the high death rates in South Africa from the very beginning, when they started those drills on outcrops in Johannesburg, people were dying. The average life expectancy of a driller, the first drillers were from England, Cornwall, many of them, was 7 years from starting to death. So the first investigations into miners' phthisis were in London. Why is that? Because the colonial system in which, the colonial system, South Africa is still a colonial, entirely under the British colonial system, and secondly, the miners who had come here and gone home to die. So there are many drivers of tuberculosis. There's TB in the mining areas. There's congregate settings in the trains and the buses and the hostels. But what I'm talking about tonight is silica dust, and silica dust is unique. It's not clay, it's not asbestos, it's not manganese, it's not entirely coal, there's some silica in coal. That's why it's unique in its effect on tuberculosis. So a case to start with. So this is a 59-year-old former gold miner seen at the Grootskeur Clinic in 2016.
Next slide.
Next slide, please. Next slide, please. He had a history. Is the generator just gone? Okay. He'd worked for 15 years as a rock driller. In 2000, he was diagnosed with silicosis, and because he'd only worked for 9 years, we would call that silicosis accelerated. It's short to get silicosis in the X-ray. In 2002, he was given preventive treatment with INH for 12 months. Despite that, in 2005, he was diagnosed with tuberculosis, and at the same time, or a few months into treatment, with non-tuberculous mycobacteria, Sessioin. They both appeared on the culture. So his treatment was extended to 50 months. In the records, a claim for compensation was recorded that was submitted to the Bureau in Johannesburg. But when he came to Grootskeur, he denied ever receiving compensation. So one never knows. Maybe he did, maybe he didn't. Sounds strange, you would forget. In 2006, after he ended his treatment, he was declared medically unfit and he was medically retired. So he came to Cape Town, as a number of miners do. Their families live there, they get to Grootskeur Hospital, and he was seen at Grootskeur, but not before he'd undergone a second round of treatment for TB. But this time there was no bacteriological evidence of TB. He'd been treated empirically, which is based on the guidelines, but with no improvement. his comorbidity, as it turned out, he had moderately severe chronic obstructive lung disease, which had his FEV1, his lung functions had declined by 40% since we had the mine records in the previous 10 years, and recurrent pneumothorax. Now, I'm just going to put up the images for those at home who can lean forward. I don't know if you get the picture. So these are the 2016 X-rays, and what we see in the X-ray is the typical bilateral nodular picture of silicosis. It's comes out very sharply here. Okay. So when you see that in the gold mining setting, it's silicosis, particularly if the person is not, it's not miliary tuberculosis. It could be, I suppose you could call it miliary tuberculosis. Again, the person would need to be sick in that setting, and a few other differential, but it's not very wide difference. The X-ray shows some areas of fibrosis. I'm not sure you can pick them up. It's not that obvious. In the right sort of middle to upper lobe, and in the right left lobe, some linear fibrosis. But if you do a CT, which most miners don't have, I won't eat now. That's not, no, most miners would not go for CTs, but he did because he ended up at teaching hospital. You see, in addition, he has a large mass in the right lung, significant mass, and invisible on the chest X-ray, and that's what we call progressive massive fibrosis. And he's also got a number of, I don't know, what look like bullae or cavities, or I don't know, chronic pneumothorax, whatever you want to call it. So he has significantly advanced lung disease. That's our case. It shows you a number of the features of silicotuberculosis and what happens to miners with silicotuberculosis, which gives some idea of what needs to be done, although much less can be done because silicosis itself is an irreversible disease. Epidemiology. If you have silicosis, your risk of getting TB is 4 times that of people without silicosis. Now, only HIV has a higher relative risk. You look at the list of things which cause TB, which cause TB or cause TB to become active or proliferate. There are obviously 2 levels. There's transmission and there's active TB, 4-fold. And yet, I don't know how it happened, but by the 1970s, the mining industry was saying that the relationship between tuberculosis and silicosis in South Africa was incidental. It was just that black miners got a lot of TB at home, and they came to the mines, they got TB. And the TB mines had good medical services, but they were not etiologically related. So the old wisdom was lost. And that is a very interesting question. It was lost, had to be rediscovered. Where there's no silicosis on the X-ray, it is trickier. Now you have the silica exposed miner. And there, once you control for silicosis, the relative risk falls somewhat, but still double. So this is a lesson we've had to relearn. It's very interesting. You think about how ideas in medicine, things are known, they're forgotten, they have to be relearned. Or the wrong things were known, and they have to be forgotten. So it's still with us. A recent gold mining screening in Lesotho confirmed that 54% of the people with TB picked up were asymptomatic. They came to the clinic, many to try and get compensation, and for silicosis. 56% of them had had a previous TB case, TB episode. In one case that we've written up, the miner had been treated 5 times for tuberculosis. But only once had they picked up TB in the lab. So what was happening is that he had a terrible X-ray and he had symptoms. And so he was treated empirically for TB again and again. And Lesotho, you'd think, because a lot of miners have come to South Africa, it's not clear that people took it really seriously. This is a gold miner. This guy's got silicosis, unless proved otherwise. We've got to find it or whatever. But no pulmonologist, no CT scanning, no biopsies, bronchoscopy. That is not what most gold miners, ex-gold miners have access to. And 25% at both. Okay, some diagnostic features. which are important: a history. Symptoms I've said are non-specific and insensitive. I'll say a little bit about chest X-ray and bacteriology. Lung function is not diagnostic. It tells us how impaired the person is. It adds nothing to the diagnostic because many miners with silicosis have normal lung function. What makes them really sick and the lung function deteriorate rapidly is they get TB on top of that. Okay, 15 minutes. Specialist, if you're lucky, or if they're lucky, and you have access, you can use specialist referral. The chest X-ray can be a nightmare. Here I've put up another chest X-ray. I'm not going to take you through it, but there you can have everything you want. You've got nodules, you've got fibrosis, you've got pleural thickening, you've got cavitation, you've got even a fluid level if you want, you've got distortion of the lung anatomy. Now, what you as the clinician and the radiologist, we as the clinicians and radiologists need to work out what is silicosis, what is old, what we now call post-TB lung disease. Is there active TB in there? Or is it all just combined disease? The chest X-ray is highly sensitive. So if the chest X-ray is normal, there's a high probability the miner does not have TB, active TB. But if the chest X-ray is highly abnormal, there's still a high probability they don't have active TB, but it's difficult to tell the difference. And this is where obviously, so radiologists and our radiologists will always teach. The radiologist cannot be sure in many cases whether the TB is active, and I'm sure that's you've been told as well. If there's silicosis or old TB as well, it becomes even more difficult. So bacteriology, and this is something if you deal with TB is probably all familiar to, the smears of limited sensitivity are the many cases negative smears of positive TB, but relatively specific. Yeah. If they're AFBs, it's likely to be TB or possibly non-TB mycobacteria. But if there's HIV, the sensitivity declines. You have to take into account. But we now have expert, which in normal settings have very high sensitivity and specificity. We don't know the effect of silicosis on expert yet. There's still to find that out. So what are the implications? A lot of empirical treatment, difficulty diagnosing silicosis. If you have the option of serial chest X-rays, sometimes that's, and you can wait, you're not sure, but that would be for employed miners. Unemployed miners can't keep pitching up for serial X-rays, or they won't. And a low threshold for referral. So do we need to extend TB treatment in miners with silicosis? So this has been controversial from the very start of short course treatment in the 1970s. Work done in South Africa at Anglo-American showed that miners with silicosis didn't need any more treatment than miners without. Same relapse rate. A study in Hong Kong, miners who got the word miner, the specialist center Hong Kong found actually that miners treated for 6 months didn't have such a great outcome. The relapse rate was quite high. They needed 8 months. And there'd be no more clinical trials. That's it. The work done by Cowie. So, but what we have done, have been done cohort studies, just following miners up. What they find is that silicotics, the relapse rate is actually 50% higher. And in some cases in India, 250% higher. Oh, sorry, the poorer outcome. So it's relapse, incomplete interruption, non-cure, relapse, or death. So there's a real concern that for some minority of miners with silicosis, they're getting short course treatments, but they're having poor long-term outcomes. So we need more research on that. For TPT, you're aware, probably you may not be aware, for miners in general, there was a massive trial in South Africa, the Tibela TB trial in the mid-2000s, in which 18,000 miners were offered INH for 6 months. At half the mines, it was by special invitation. The other mines, it was just the mining policy as usual. And what they found is that when you want treatment with, or latent infection treatment, INH, your risk of TB plummeted. INH works. But when the INH stopped, within 6 to 9 months, the TB rates in those mines were back up to where they'd been. So INH for working miners was unable, as they had done elsewhere in the States, the United States, the 1960s, to sterilize TB, community sterilization. I mean it in the TB sense, to basically treat the latent infection out of the community. So for miners with silicosis, even more difficult, and it was even recommended they get 36 months of INH. But it's really quite problematic. We don't know how long you have to offer a miner with silicosis treatment for, but now we have the option of a shorter regimen, more expensive, using rifapentine and INH rather than INH alone, but we really don't have the answer to that. I'm just going to, perhaps, have I got any more minutes? Next slide, please. 10 minutes, okay. Next slide. Yeah. So medical surveillance, miners generally under the Mine Health and Safety Act required to be, if they're at risk, to be X-rayed every year. The problem is former miners. They are not covered by the Mine Health and Safety Act. They are covered by ODIMWA, Occupational Disease and Mines Works Act, which is the Compensation Act, and that provides an important benefit. They're entitled to be examined every 2 years, but only until they've got maximum compensation, and then that stops. But in most cases, they never get examined again, unless Lesotho, Mozambique, they get sick. They'll be examined, there'll be no occupational history, and they'll never be, not never, unlikely. If you're in Mozambique or in the hills of Lesotho, maybe Botswana and Eswatini, you have a better chance of having claims sent to Johannesburg, but even the Eastern Cape. So in the recent years, there's been a huge outreach effort, big outreach effort by the Medical Bureau to try and find the miners and offer them an examination. But actually another group of people got involved, and I come back to my first statement, occupational disease and negotiated disease. And these people were the lawyers. What they do is they sued the industry for miners who got silicosis and tuberculosis. And it was settled. It was settled for 6 billion rand. That led to the formation of Chamisa Trust. So people sat around a table and they agreed that if a miner is diagnosed with this very tight silicosis, TB, when they got it, whatever, that follows ODIMWA quite closely, they get money. So that's the miners who come and be examined. So it's sort of almost like a full circle. But that doesn't mean that all ex-miners will be covered, and the trust ends in 12 years. The gold mining industry, I don't know, may outlast the 12 years, I don't know. The problem for working miners who have diagnosed with both diseases is that they are moved to low exposure settings. But in many cases, there's no job on the surface. So that's the end of the mining career. And that's required by law. And I'm going to end it there. Slip slide. And so I don't know, thank you. I don't know if we're going to find a way or time to do questions, but
I think there's time for questions.
okay. So how are we going to do that?
The questions online.
Okay. So whatever time we have available, be happy to take questions.
My start maybe with the first question.
Yeah.
Will you just repeat the
No,
question?
yeah, I'll repeat it.
In the primary care setting, what is the current way of diagnosing, acceptable way and method of diagnosing TB? Is Ziehl-Neelsen still maybe for the adults X-ray, or is just the TB gold serum?
I'm not going to be able to answer that question because you're talking about the general treatment of TB in the primary care setting. So I'm sorry, the occupational health setting is the thing I think about. But there's somebody in the room who can ask that. Primary care, what is the standard for treatment of TB in primary care, irrespective of occupational diagnosis? Sorry, of diagnosis.
Just Ziehl-Neelsen?
So Gene, the answer to that is should be using Gene Expert, which implies it's universally available.
Yeah.
And it seems from TB programs elsewhere it is. So it's certainly now an essential component. But the question is whether you go to gene expert immediately, or you go via chest X-ray. Symptoms? Symptoms? So you still go via chest X-ray. And if the chest X-ray is negative, and they're symptomatic, you could go to gene straight away, because in the there is a small proportion of TB cases that are X-ray negative. So in the Lesotho study, 6% of the people with TB had normal X-rays. But still, it enables you to triage, particularly if you're uncertain about symptoms. Next question.
Question online. An employee with MDR TB, when can this employee return to work?
I don't know the answer to the question. So they have to be negative. They would need to be culture negative, and they would need to be fit. And it would have to be done in consultation with the people treating them. So it goes to being non-infectious and sufficiently fit, because treatment with MDR is a grueling treatment, and many people with MDR are not well for a long time afterwards. So I think that would need to be managed on a, from the point of view of protection of others. The issue is infectiousness, but the point of view of the person being completely rehabilitated, that would be on an individual basis.
Another question. What type of masks or respiratory protection should healthcare workers be wearing? Well,
if healthcare workers are exposed to open tuberculosis in settings in which there's no, well, in general, they're close contact, or certain, it might differ, but N95 respirators are what are required or equivalent. Next question, please.
Circular, this is a longish question. Circular instruction 179 states that TB in a worker with silica dust exposure for 2 years shall be presumed to be work-related. There's no definition on the level of silica exposure. I've asked the occupational hygienists, they are required to report exposures more than 10% of the OEL. So that would seem to be the level to use. Can you advise?
Well, I think the I would agree with that, actually, because the question is really this: if those specific guidance is given, and a term such as it had silica exposure, then it's not actually up to us to have to make an ad hoc decision about we consider sufficient silica exposure. It might well be they could have said there has to be evidence of exposure greater than 50% of the OEL or at the OEL, but it doesn't. So I would agree with that. You might say, well, there are workers who, how do you know it's silica? That's not really the discussion to have. It's been negotiated. By that, I mean, it's now, there's a legal framework, and we should follow the legal framework as it may adapt to the science, or as it may emerge in the future, it may be changed. So I would agree with that. If silica exposure is reported, if the 2-year mark has been reached, it shall be deemed so. Why make life difficult?
Can we give an employee who is exposed to silica INH for a long time?
Well, there are, okay, so there are specific, the National TB infection treatment guidelines, which have came out fairly recently, in fact, has a section, and I think it's devoted to silicosis, in which they suggest either 3 months with rifapentine and INH, or 12 months with INH. If you take the Tabella TB evidence, which showed that in the longer term, it does not prevent recurrence of TB at a community level, you might be reluctant. However, I think it's a very difficult question. If someone had a lot of silica exposure, okay, let me bring this, which I haven't actually made an issue of it, and it does influence the decision-making process. 65% of silicosis is not visible on the chest X-ray. We know this from autopsy studies. Now, most of that 65% have fairly limited pathology, what we call mild, few or not infrequent nodules in pathology. But in fact, about a third of those with many, or I don't know the words they use, moderate or severe nodulation at autopsy, that also doesn't appear on the chest X-ray. So now you have someone sitting in front of you who has no silicosis, but they have silica exposure. You need to take into account they may have silicosis. And I think their length of service would be an indicator. So if you have someone 30 years of exposure, I would reckon the chances of them having subradiological silicosis is high. If they've got 2 years of exposure, not so. Where's the cutoff between? I don't know. So I think you need to take all those factors into account, and it may well be a reasonable medical practice to offer that person INH. Oh, sorry, not INH, particularly if they're prepared to go on the 3-month regimen and they don't have active TB, obviously, and they tolerate the medication and it's affordable.
Regarding other manufacturing processes, medical surveillance in other industry where silica dust is used, is this also, I presume, compensable, or is this also a risk? The question doesn't state that.
Yeah, we don't believe there's a difference between the silica dust in mining and the silica dust in industry. The migrant labor, there's other contexts for tuberculosis, migrant labor, hospital accommodation, and so on, that might influence the rate of TB among those with silicosis. Sorry, just repeat the question again. Yes, sorry, I've just lost it's to do with...
disappeared off my screen.
Sorry, is it about silicosis or TB? Sorry, I just lost the track there.
Medical surveillance in other industry where silica dust is used in the manufacturing process, is this also?
Sorry, I'll tell you what confused me. We're not talking about surveillance for silicosis, although that's part of it. And that should follow, that should be risk-based, depending on measurements of silica and who's exposed. It should be, you would follow the guidelines, and it's between 2 and 3 years, every 2 or 3 years. But the surveillance for tuberculosis would, I think, be based on also risk assessment and ideally on some understanding of what the TB rate is among the workforce. Now, it may well be workforces who come from very high TB areas, and this is the thing in Cape Town. Some of the areas in Cape Town are some of the highest TB rates in the country. So what you would be doing is a combination of public health and occupational health. And it would be, in that case, good public health to be looking for TB among your workers. And you'd have to decide whether an annual, in this case, would be probably X-ray is the best. You'd have to decide. What I'm saying, I think, is that you need to adapt to the circumstances and not necessarily be bound by a strict rule of surveillance. I think the Occupational Health and Safety Act requires a risk assessment and then appropriate surveillance. Is that be correct? I don't think it specifies how often the surveillance has to take place. So if you're the OMP, in a sense, you'd have to put it all together yourself, but you wouldn't be bound by the Mine Health and Safety Act requirement, or you wouldn't have ODIMWA terms to be guided by.
And then a last comment from Prof. Adams at UCT, speaking about Circular Instruction 179. She says, no more circular instruction. Please note that this has been replaced by a regulation now. So just for people's,
Yes, two important regulations. Thank you, Shahida. One refers to TB in I think the healthcare setting, and as far as Shahida can correct me, but I think previously a lot of managers in the healthcare system said that TB is not, the individual has to prove, the health worker has to prove they got TB at work. So I think it's the first time the regulation appears in which the word presume, and presume in the compensation setting, says that if a certain situation is there, in this case, exposure to a place where there are patients, people with open TB, the healthcare worker who develops TB shall be presumed. So it's a big step forward. In the silica in industry, as Shahid has pointed out, I think it says, does it specify? It may specify. I think it also specifies a 2-year exposure, and that TB is also compensable. TB in someone who's exposed to silica in industry. So that ties up with the earlier question.
Okay, good.
Thank you.
I'm wondering if we could just take a 1 minute, 2 minute break, and then we'll set up the next. Can you just announce that?
We're going to take, sorry. Yeah.
Louis, go for it.
Louis, yeah.
Thank you, Prof. Earlis, for a enlightening talk on a very difficult, very challenging subject. Thank you very much for that. We appreciate. Hopefully, you'll come and visit us in the Kalahari again. So, just to prepare for the next presenter, let's take a 1-2 minute break. Please don't go away, and then we'll ask Dr. Jim Tavatanudea to do his ethical considerations in running an asbestos disease compensation trust. Thank you. Let's see, 2 minutes. Thanks.
Sure.
I'm happy.
Yeah.
Going back to this idea of we understand that there's a regulation now that presumes any health worker to be compensated for TB, considered as a occupational disease.
If they've,
The fact that there's
so-
no
yeah.
baseline in most of new recruitments, it won't affect the standards of the regulation, because the compensator might request the baseline or the simple presumed meaning of the regulation should help.
It's a very, very good question. So the regulations have just come out. So these are important questions because, for example, hearing loss, you have to do a baseline to make sure that, so that the hearing, you may have come in with hearing loss. So what are you going to do at baseline? Let me ask you the question, because it's a good one you've asked.
For TB, you might say, okay, when the doctor or the nurse go to recruiter, we have an X-ray that was done is a baseline or is an entry. But for the case, for most of the equipment, X-ray is not really done. It's a baseline.
Yeah. So I'm going to push you on this. Okay, so what are you looking for in the X-ray? Let's say somebody comes in and they've got some scarring. No, but this is the problem. They come in with active TB, you've done everybody a favor, but most cases, yeah. But what about a PPD or a blood test for TB infection? No, but they're latently infected. Let's say you do PPD is positive. If you go to the States, you can come in from, I don't know, a place where they've never seen TB, you'll get your PPD. And if it's positive, you go on to TPT. Doesn't care in the healthcare system. But we don't do that, and there are many reasons for that. Of course, we're suffering from a TB epidemic, we don't have the resources. But you have to think it through, you see. So I think that's what, hopefully a regulation like that will now stimulate, that either the circular instruction will be developed to, or perhaps from Sessioin, to develop a system which is resource adapted to the resources that we have for some sort of baseline consideration. But it has to be, it can't stop there, because people get infected or they develop asymptomatic TB at work. And the problem is how to find them early, before they've infected colleagues or patients, and before their TB is advanced. Because what we're seeing now, there's now a lot of interest in what they call post-TB lung disease. which is many people never, their lung never actually recovers from TB. They don't have tuberculous disease, but they have airways obstruction, and they've got, scarring, fibrosis. They've got bronchiectasis, very common. They're subject to increased rate of infection. So their life, the quality of life may well be affected. Anyway, sorry.
Yeah.
Taking your time. Thank you.
Can you just summarize the question and your response? Because the delegates online didn't hear the question. You said it was a good question.
Oh, sorry. Yeah. A colleague has asked, sorry about that. I've sort of so many boards in there. A colleague has asked whether healthcare workers, as perhaps they used to be, should not have a baseline examination for TB when they're employed.
Thanks, Rodney. Thanks very much. So 1 minute. Thanks. I'm amazed by the technology.
Yeah.
It works. Yeah. I just want to see now. So we're going to close this. And Rodney, could you get me one? Just any water, please. Thanks. Hi, Claudia. Can we start in 30 seconds about, please?
Yes, no problem. You just need to unmute yourself, Jim.
I'm unmuted. And
Yes,
can
we can hear you.
I'm trying to minimize my Zoom webinar window. It's not cooperating. No. Well, I'll move it to the one side. That's fine. Okay.
Is it not playing?
So am I seeing that the first slide has started? I
Yes,
think
I've started sharing the first slide.
if we can move on 3 slides, please. We are in the interest of time. So I'll move mine as well. And can I start talking? Can I start talking? Stand up. Okay, we're going to start. I've got a screen on behind me, and I hope Claudia can see that. Claudia is advancing the slides in Pretoria, and we're talking here in Kuruman. So thanks once again to Sessioin, to Cipla, and to Asbestos and Kgalagadi Relief Trust in sponsoring this event. So I elected to talk on this, which I've entitled Ethical Challenges in Running an Asbestos Compensation Trust. So just to speak about what the setup is, this is the next slide, please. The setup is the Asbestos Relief Trust was founded in 2003. About 480 million rand was available. It needed to be allocated to compensate qualifying claimants all over South Africa, with the money lasting 25 years up to 2028. Trustees and staff were appointed, a medical specialist panel was appointed. And the question is, how could the trust dispense its mandate ethically? Moving on. So some basic principles of what ethics is, or medical ethics. It's not the same as feelings. It's not religion. It's not following the law. It's not following culturally accepted norms, and it's not science. What it is, what ethics are moral principles. And then I've struck out here what is good and bad, what is right and wrong. That is quite often in the parlance used when describing ethics, but it's actually about what is fair. That's a better description than going to these oft very difficult questions to answer. What is good, what is bad, what is right, what is wrong. So what is fair is it's a good set out, or it's a better set out of the issue at hand. And I have my colleague on my left, Prof. Ehrlich, to thank for that. It's based on value systems, and ethics are everywhere, but the same norms are not universal. Different, it depends on one's societal substructures or subcultures. It refers to standards of behavior that tell us how human beings ought to act. There's another fraught item, or how ought you to act in the many situations which they find themselves as parents, friends, children, business people, teachers, professionals, medics. Historically, medical ethics can be traced to guidelines like the Hippocratic Oath, and that's essentially, it's got a few items that that one can speak to. You recognize patients first, they're first and foremost, and then, but you also need to take into account society. You have responsibility to other health professionals and to yourself, which is quite interesting. These aren't laws, but they are standards of conduct which govern behavior. Next slide, please. So you've probably all seen these names: autonomy, beneficence, non-maleficence, and justice. So autonomy is about respecting the individual. Patient has freedom of thought, intention, and action when making decisions. They should understand risks and benefits of any procedure, anything you undertake to them, including likelihood of success, and be free to choose. I left out a poem that I wrote in 1997 because of time, but that was one of the free to decide is what the poem was called. And that is an aspect of autonomy, an aspect of good ethics, upholding an ability, another person's ability to choose. So, and as it says here, it's not simply a matter of attitude, but rather a way of acting. It's a thought process that you get yourself into. It's deep respect. I think we can move to the next slide, please. So that we've covered autonomy sufficiently. Beneficence is doing good. And so this indicates that the practitioner should act in the best interests of the patient, whatever that is. But with the other aspects of what you are looking at also weighed up and considered. One of the items here is that this needs the healthcare provider to develop and maintain skills and knowledge by, for example, attending CPD events. Non-maleficence means above all do no harm, so doing no harm. And these aren't nothing in these discussions are absolutes. They're all weighed up against other considerations. So one of the discussion points under non-maleficence is, can one use morphine to ease a patient's breathing who is dying of heart failure from lack of albumin in the blood? So when you know that the decreasing the respiratory drive will hasten hasten the end of that person's life. Justice is understood as the distribution of scarce health resources, the decision of who gets what treatment in terms of fairness and equality. And there are four main areas here which one should take note of. Fair distribution of scarce resources, competing needs, rights and obligations, and potential conflicts with established legislations. Utility is a concept that was introduced in addition to these four bioethical principles of Childress and Beauchamp, or is it Beecham? I'm not sure, but Beauchamp. But Beauchamp can be pronounced Beecham.
Oh, really?
For the utility means for the greater good, and that's sometimes added to the mix. So next slide, please. So now to understand compensation, when it goes to this aspect of damages, and to start off with, one needs to say there are many different understandings of what damages are depending on your jurisdiction, the jurisdiction you find yourself in. It's generally defined as a monetary compensation for an injury, a wrongful deed against you. The legal objective is to restore the person to their prior position. But this has two important limitations. The first is that no amount, no compensation can fix generally what you've lost. And secondly, the monetarization of damage is often subjective. Next slide, please. We're going through the types of damages that get spoken about. They're compensatory, which is compensation, which we talk about, nominal and punitive damages, and those have all have relevance here. compensatory damages go to people. That's the only thing we're discussing, compensation damages to people. And we're not discussing damage to the environment or damage to history. It's given to compensate for loss, an injury, or harm suffered by someone else's breach of duty. There are a number of South African examples. The Macassar sulfur fire in 1995, that came under some sort of compensation damage. There wasn't much of that. The Cape PLC case, there wasn't in the Macassar sulfur fire. The environmental damage got nicely compensated, but not the personal damage. The Cape PLC case in 2003, that was Richard Meeran, which was essentially settlement around Priska. The Gencor case, which led to the establishment of the Asbestos Relief Trust in 2003, and relatedly the Kgalagadi Relief Trust in 2006. Both of those were run by Richard Spoor. And then more recently, the Quebeca Trust in 2016, run by Richard Meeran again, and the Tsiumiso Trust, which was finalized in 2019, and that was Richard Spoor and others. Next slide. Nominal damages are small amounts of money awarded to plaintiffs to acknowledge that they were right, but did not suffer substantial or substantive harm. It's a small anecdote here. Churchill was once accused of being drunk, and he won his case, and the court awarded him 25 cents. So punitive damages. This relates to the Exxon Valdez case of an oil tanker which ran aground in Alaska, somewhere in Alaska. And this is where the court recognizes that compensatory damages by themselves aren't enough. They need to create some sort of precedence by or some sort of recognition that this was actually the behavior of the person who caused the injury was reckless, and therefore they award punitive damage, also called exemplary damages. They might make an example of the case. I'm not sure that we need to discuss this, but basically the captain aboard a ship was before he got on the ship, he had consumed so much alcohol that would have incapacitated a non-alcoholic. And then at the time that the most important task of navigating the ship through a very small passage occurred, he left the bridge of the ship, and he left the ship in control of non-licensed colleagues. So the basis of the punitive award was relatively simple. The next slide. The court established that the Exxon company was in breach by continuing to employ this person. They knew about his history of alcoholism, and although he was treated, they hadn't monitored that he had continued being positively treated. Next slide. The quantum of the award was 5 billion. And that was, this was in 1994, so I haven't worked out how much that is now. It was later that year reduced to 2.5 billion. And the guidelines the USA courts used for punitive damage up to this case, when this case finished, was that punitive damage should be on average about 4 times, if you've shown recklessness, 4 times what the compensatory damages are. Or you can only use a single-digit multiplier, so it could go to almost 10 times the compensatory damages. The Supreme Court in 2008, however, issued the landmark decision in this case that punitive damages should not exceed the compensatory damages, and so that reduced the punitive damages to about 508 million. In South Africa, punitive damages are termed exemplary damages, as I've mentioned. Punitive damage are generally not applied in European law, and usually not in Roman Dutch law or in South African law. Recklessness must be shown, and tests for that are quite stringent. The next slide, please. It's titled Exemplary Damages. In related to asbestos-related disease, exemplary damages are rare. And the situations where punitive damage might be considered are where there's been gross negligence or fraud or deception or violation of regulations and history of misconduct. When speaking to lawyers, these are really high bars. You might want to say that, well, obviously the asbestos companies knew that asbestos was bad, and they far exceeded the regulated number of asbestos fibers per milliliter of air, or whatever it was in the co-limiter days. The truth is that bar is quite high, quite hard to prove. So you usually cannot prove these that the operator or the person that you take into court was indeed reckless. Next slide. So compensation damages are essentially damages to people. It's against people they're associated with physical or psychological injuries. The person can lose an arm in an accident or be subjected to serious psychological harm, shock, or lose their life, as with asbestos-related malignancies. Damages are divided into general, which is pain and suffering, and specific, loss of future earnings and medical expenses. So this is that set out of how damages are divided. Are there various ways of setting that out? There's economic and non-economic, which and they go into more detail than what I've just shown you now. But it's, for example, loss of marital enjoyment. That's a non-economic loss. That would fall into general pain and suffering. But it's in the case of the Asbestos Relief Trust, these were the items that were used and used to determine the quantum of damages that would be awarded by the trust to any claimant who comes forward, qualifying claimant who comes forward. So there are a whole number of considerations that we can look at. Next slide, please. So in the ethics universe, what we are talking about here is applied ethics or practice ethics, practical ethics, the application of ethics to real world problems. So this includes things like medical ethics, biomedical ethics, or business ethics, engineering ethics, and their likes. They're all branches of this thing called applied ethics. Understanding the others is, I suggest you might want to take a university course. I certainly have no closer to understanding these bits that we don't go, but that we aren't going into. But just to name them: normative ethics, a branch of philosophy that develops moral theories, such as the ethics of care or deontology, about how people make choices that affect their decision-making and actions. Quite interesting and possibly circular. And then meta-ethics is a branch of philosophy that asks questions about the nature of ethics, such as what is morality and how do we make moral judgments. But we're not going there. So next slide, please. So as mentioned before, our ethical codes, we have ethical codes that we work with, started probably with the Hippocratic Oath some 2,500 years ago. And it requires of a new physician to swear upon a few healing gods to uphold several professional ethical standards. We'll come to those. It also strongly binds the student to their teacher. And the creation of the oath, it's believed, may have marked the early stages of medical training outside the first families of Hippocratic medicine. Those people from the Isle of Cos, where the lettuce is also named after, by requiring strict loyalty. So as people under that code of medicine, Hippocratic medicine, 2,500 years ago, as that expanded, they started taking this Hippocratic oath. That's what's believed. Over the centuries, this oath has been rewritten, often to suit the values of different cultures. And this is specifically, I've highlighted that in, I've emboldened it to say that this is what ethics is about. Values in different cultures, that the cultures that were influenced by Greek medicine. And contrary to popular belief, the Hippocratic Oath is not required by most medical schools. We hear this quite often with some mirth in TV programs. And although most have adopted modern versions, and also specifically, it doesn't use that phrase, first do no harm, which is commonly attributed to it. Next slide. So here's the Hippocratic Oath, as translated by Michael North, and it's in smaller print, which means I don't really want you to read it. I swear by Apollo, the physician, Asclepius, and Hygeia, and Panacea, and all the gods and goddesses as my witnesses, etc. It's clearly not suited to our current age, but I did think I would, there are a number of things I want to pull out here. One is I will not give a lethal drug to anyone if I'm asked. There's something against abortion. I don't know where that is. And I will not give a pessary to cause an abortion. These values have changed. So that's what, and then I thought I would show you what the god Panacea looks like. And there's a picture of Panacea. And Panacea is known for her ability to cure all ills. As you can see, this is Panacea from Asterix, the Asterix and Obelix series, and the little dog Dogmatix is clearly quite besotted by Panacea, the cure for all ills. Next slide. The American Medical Association is the first of the Western countries to adopt a medical ethical code, and they've always called it Principles of Medical Ethics. The first version came about in about 1847 or 1850, around that time. This is the 2001 version, although one can find different dates for this particular version. I've read 2005 and 2016, or 2017, but this is clearly the 2001 version. And then the previous main versions of this were 1980 and 1957. Next slide. This is the World Medical Association Declaration of Geneva, and it's called the Physician's Pledge. And this is a major upgrade from previous previous declarations, such World Medical Association declarations, that over the past 50 years they've updated, or 70 years they've updated from time to time. But this was a major upgrade. And interestingly here, what they say is that usually previously they spoke about, I will honor my teachers. Here they say, I will honor my teachers and my students. I will give to my teachers, colleagues, and students the respect and gratitude that is their due. That was an advance in this in the physician's pledge. So next slide is ethical codes across religions, and just what this tells us about human beings is that the religions virtually all have this. It's a reference. Ethics is essentially how you are going to best treat the person next to you. That's what all these different religions, what the common thread through these statements that the religions make. Hurt not others with that which pains you. Whatever you want done to you, do to others. No one of you is a believer until they love for their neighbor what they love for themselves. What is hurtful to you, do not do to your fellow human. And then I added into this list, I added Ubuntu, which is humanity to others. I am what I am because of who we all are. A big statement in understanding that the person next to you has the same type of complex feelings, the same as you do. There's a concept called Sonder, S-O-N-D-E-R, which I urge you to look up, which states that it's a realization that the person next to you is full of contradictions and desires as much as you are, and complexly so. So it's so this is what ethics is about. It's considering the other. So next slide. So the commonalities in ethical codes are these headings that I've put up here. This is across medical schools. It's across these different medical associations across time, but ethics changes over time. So it's current to now. There's a service aspect. There's a promise of integrity, honesty, humility, and compassion. If you do harm, it must be outweighed by benefit. Gender, race, religion, political affiliation, all those isms that we speak about, they should not influence the physician's judgment. What wasn't in that list was age. And as someone who's increasingly grey, one notices opposition to breaches of human rights need to be spoken out against. Recognition of mistakes in self and others, and to learn from them. Jim Tavart and the Deer can tell you that when looking at a man with asbestos exposure, he saw a pleural effusion, a unilateral pleural effusion, approximate that he guessed was about 200 milliliters, and he sent it for investigation. The person he sent it to for investigation said they could not do the pleural tap, which he wanted, and that was where Jim Tavart Mudia left it. Except 5 months later, the person, the case next came to my attention, and the person was in extremis or very close to dying in Groote Schuur Hospital. So I mean that was a failure, and that's my story. So how can I change that in future? That's a question. Teaching those who come after us, as well as our colleagues, is one of the issues, commonalities, and then the oath and adherence. This oath and the adherence to it are freely made and are made without coercion. So the next slide is again on ethical codes. The commonalities in religious or ways of life, ethical codes are concern for the other. We've discussed that medical ethical codes have about 8 common approaches, which we've just discussed. There's sacred trust invested in the medical doctor. I'm saying medical doctor, I could say healthcare worker, but I didn't concentrate on healthcare workers. I looked specifically at medical doctors. There's sacred trust invested in the doctor that allows a sick, hurting, injured patient, a stranger, to approach a doctor and be treated in a dignified manner with an expectation of improvement. It's an expectation and an exhortation and aspiration to be honorable and to do the magic that this profession of medicine can. So we're back to the Asbestos Relief Trust. When the Asbestos Relief Trust has employed some doctors, and those doctors in effect led quite a number of the ethical decisions because of their conduct. We'll come back to that. So now, from the trustee viewpoint, what are their ethical issues that they needed to look at? And one was inadequate compensation. Did those tables that they produced with the help of an actuary to quantify pain and suffering, loss of earnings and future medical expenses, were those sufficient? The primary concern with any compensation is it enough? They might not, especially for long-term care. I just need to take some water. One of the issues that we have tried in the Asbestos Relief Trust to do is not to delay compensation, and especially where the person has a predicted shortened lifespan. So in the cases of mesothelioma and lung cancer, we've certainly tried to move all our resources to get a quicker compensation outcome. Even if it is to say no, we have tried to do that. In terms of inequitable distribution, one of the concerns is that everyone needs the same access. At the beginning of the Asbestos Relief Trust, it was assumed that people would just bring their chest x-rays to the medical doctors, and the doctors would then look at them and say, well, there's the asbestosis, you get, you are on code ARD1 or ARD2, whatever the certification was. When the trustees realized that there was no access or no automatic access to services, they paid for services. They paid for doctors like Dr. Ellis to see the patients with a good clinical, a good lung function test, and a good chest X-ray. And they also paid for their transportation, and in some cases for accommodation and food. Another concern is lack of transparency. And I'm not sure that I can point to any examples that we have that easy to explain examples, except to say that we strive to, where people ask us for information, we try to give the information, noting some legal concerns around that, POPIA and PIA being some of them. But again, it's the tradition that where we come from, that we hold the autonomy of the patient and their privacy and their dignity, we hold that in a high esteem. Next slide. More trustee considerations. Conflicts of interest. one of there have been a number of conflicts of interests in our in between our trustees over the years, but they did realize at some point that once they historically the trustees were set up as two representatives from the workers' side, two representatives from employers, the mining side, the asbestos side, and one independent. They realized after a while that when they stepped into the trustee boardroom, that they were all there to represent the best interests of the beneficiaries, future and past. So that took a while for the trustees to understand. And after that point, one didn't find that there were significant conflicts of interest. Burden of proof, what the Asbestos Relief Trust did, we don't believe that we have a particularly high bar for people to clear. If there's proof of exposure and there's proof of effect, then so in other words, they were exposed to a mining operation and they do have some damage in their lungs, we believe that is sufficient to award the person a compensation amount. What the trust did was to go to great lengths to digitize all the work records that they could find. They did this over a period of approximately a year, where they had an office here in Kuruman where they fed documents after document into a electronic scanning process which digitized it, and that has since become a digital index. And then similarly, if someone worked for 1 week and they have a record of service, we believe we haven't stood in people's way to say this is insufficient exposure to cause the disease that they're coming from. It was the fact that they had a record of service was sufficient. Access to healthcare. One of the biggest things that the Asbestos Relief Trust did was to recognize that people who had mesothelioma, they were not just compensated, they also got post-compensation care, or care which we have then extended from testing, first testing to the grave and possibly beyond the grave, because there are services that we can offer to their families. We instituted in 2007 a palliative care service, and sitting here in the audience in Kuruman are our 2 palliative care nurses, and they have done a superb job in improving access to healthcare for those people in the post, after they've been compensated. We didn't stop at compensation. And then long-term consequences, we've always tried to keep in touch. We've got a database of about 19,000 people who've ever approached us with some sort of bona fide claim, and we will keep in touch with them in ongoing basis. Next slide. So the ethical challenges of compensation bodies, and I just made the point here that there are many of them and the decisions are quite complex. And that's essentially because they involve both process and content, and often there's no precedent that we can look at. I just wanted to, having said nice things about the trust now, I wanted to make a comment here on that reliance or trusting on the system. I'm not sure. Well, I must have made a typo there, but relying on the system is not sufficient. And this is a brief paragraph from some of the Holocaust literature, and I read it, and talking about the system. A political, economic, or cultural system insinuates itself between myself and the other. If the other is excluded, It is the system that is doing the excluding, not the person. It's the system in which I participate because I must survive, and against which I do not rebel because it cannot be changed. That system cannot be changed. I start to view horror and my implication in it as normal. And then similarly, there's a movie on Netflix at the moment called Ordinary Men, The Forgotten Holocaust. And that's a documentary which examines how and why thousands of ordinary Germans who were carried out mass atrocities, mainly in Poland, as members of Nazi police squads during the Holocaust. Basically, they shot women, men, and children to their face. And that was responsible for about a third of the Holocaust deaths. These were ordinary, before the war, these were ordinary people. They weren't part of Nazism. They weren't SS. They weren't stormtroopers. They were just ordinary people that in 1941, they were asked to join or inscripted to join this force that went to essentially an occupation force in Poland and other places, and the horrors that they carried out were, well, you'll see it in that movie, which I encourage you to watch. So the system, the issue here is that where the individual gives responsibility to the system, you are in danger. So please do not think that the system, just because it's part of the system, it's not good enough. You need to think ethically. You need to think about the other. I didn't know how much time we had, so and it looks like we're out of time. So I'm going to shift through the next. I'm just showing you some pictures of that. These are real diseases that we're talking about. Asbestos ores and lung dust regions and diseases that affect real people. The difference between probably us and them is that they were exposed to asbestos. So this picture of the cancers it's grim. So now I suppose we're coming to the nub of it. How do you apply a medical ethics approach? You identify the ethical dilemma, and that's not always obvious. With informed consent, end-of-life decisions, allocation of resources, conflicts of interest, things you might only remember, you might only realize afterwards, after you've taken these decisions that have affected people's lives. You need to gather relevant information. You need to collect, use ethical guidelines, and I've given you some some suggestions. Apply ethical principles and ways to do it, but noting that we've gone wider than just those 4 things of autonomy, doing good, not doing harm, and justice. It's a wider discussion than just that. Those 4 ethical principles of Beauchamp and Childress, they refer to a very narrow part of ethics, mainly in the doctor-patient relationship. Communicate and involve the patient. There should be shared decision-making. Make the decision, implement and monitor if you've been aware that you've made a decision. And then this last point, documentation and reflection. So in my practice, I've never done this, or I might have done it once or twice. And then reflection and learning, reading up, learning from what you've experienced. Part of the of good ethics in running a compensation system is that there are diagnostic challenges, and one has to recognize that. there are many differential diagnoses to these things that appear very clear at the end of the day, but the diagnosis might be wrong. There are many causes of pleural changes. There are many causes of interstitial lung diseases. That's what this set out below here is. One of them in the blue, the third box down, that is pneumoconiosis. And there are many pneumoconioses. So just good medical practice, knowing what's out there is part of good ethics. And similarly with lung cancer and mesothelioma, the diagnosis is not straightforward. But science has made it easier for us in the past few years, we must say. And then, as I was discussing with doctors at a few hospitals this morning, how do you approach the unilateral pleural effusion? This is in this area. If we had a good approach to unilateral pleural effusion, I'm sure we would have less suffering. So we're back to the setup. Asbestos Relief Trust, found in 2003, 480 million was available, need to be allocated across time and across people all over South Africa, across different diseases. And we had to have a good indication of who was going to get what diseases when, and the money had to last 25 years. Staff and trustees were appointed, a specialist medical panel was appointed, and that panel adopted along with many other pieces of experienced judgment and advice. They adopted the Kuruman Hospital standard of care. Standard of care being what we should expect to what standard of care, what investigations, what medical approaches we could take to people that came in front of the panel, that got seen by people like Dr. Ellis, Dr. Foster, Dr. Grobler in this town, Dr. Piri in Burgersfort. How can we adopt an approach that will stand up to scrutiny? And we decide on the Kuruman Hospital standard of care that even if there's nothing that we can do for the patient, we can still care for them, by, for example, palliative care, a number of other issues. So how could, and the question was, that was one of the ways that we could answer the question, how could the trust dispense its mandate ethically? What we had, excuse me, were hardliners on one side, and on the other side, less hawks and doves. Some 19,000 people got registered, and the ethics is still down to basically compassion, how we could be compassionate towards these, our fellow human beings, versus certainty, which was the other side of the equation. How do you make this money stretch for 25 years? So the question that I suppose we need to ask ourselves is, did we achieve ethically optimal outcomes for a high percentage of the people who came our way? Thank you. Yeah, if there are questions, I don't know where I am.
Time for questions, yes.
There's time for questions. Let me end the slideshow.
Take one question in the room first, Jim.
Yep.
Sorry.
Yeah, I want to just understand, I don't know if I should call it a question or a clarity. Or as a doctor, or we have to refer or to advise patients who are affected with lung disease related that might be asbestos or any disease was related. So I wanted to understand what is the relationship between the industries like mining companies, asbestos trusts, and patients affected by asbestosis, and other patients who are ex-miners. Because we see many miners with asbestosis that will never work in the mining industry. And we still refer them to asbestos for assistance. So what is the relationship between the four groups, like ex-miners, patients who never been affected directly by the mining industry, and the asbestos trust? If there is a relationship, is the mining supporting the asbestos trust? Is the first cause of this disease, if you can say it? Is a patient who never been affected by the mining should be only referred to the asbestos trust? Should the ex-miner lodge a complaint or like request a compensation from the mining industry separately, and also being assisted by the asbestos trust? All those are questions that we usually would ask.
So I'd need to summarize your question just for the online audience. The relationship between the trust and the mining houses, and then you wanted to know about how are ex-miners treated, and then also, as I understand, how are environmental cases treated. Just in summary, would that be about right? So the relationship, the Asbestos Relief Trust was formed by an out-of-court settlement between GenCore mainly, and which was a mining house, an employer of mine workers, and the lawyer Richard Spoor. And then that created, where the out-of-court settlement created the Asbestos Relief Trust, with the mining houses forwarding all the money to form the trust. And that money was entrusted to the 5 trustees who were set up, and that's how. So there's no relationship that ended any relationship between the mining houses and the trust. All asbestos mining in South Africa had ceased by about 2002. In this area, in Kuruman area, it ceased in 1998. And the other big production area in South Africa, in Penge, where they produced amosite, it ended in 1992. So once the relationship between the trust and the ex-mining houses now is just one. It's required of all trustees that they adhere to the requirements in the deed of trust. It's like the constitution of the trust. So that's the ongoing relationship. Although there are no mining houses left, they've all atomized their interests into their shareholders. Ex-miners, so anyone. In no current asbestos miners, they're all ex-miners, and they are all except in the qualifying miners or qualifying ex-miners are those who worked for certain mines which are named in the trust deed. So there's certain miners in this area, like who worked at Vandrach or a place called New England, who don't qualify. And then the other side of this, you asked about environmental cases. Environmental cases, if they've been exposed, and there are rules that we've had to set up to make to act on the certainty side. We set up certain rules. So people who lived within 10 kilometers of you draw a radius of 10 kilometers around the mining operation, ex-mining operation, they would qualify if they lived there. or if they were exposed to one of their parents who would have come home with with asbestos in their overalls, and that got washed the overalls got washed at home, they would be similarly environmentally exposed. And we've compensated many people for environmental asbestos exposure and disease and subsequent disease. Is that
I think you also asked about
Sorry.
women who had been exposed working, cobbing,
right?
and not employed.
So it's an unfortunate part of our history that there were a number of women who worked for their husbands or for their family and were very directly exposed to asbestos, holding the asbestos ore between their knees and smashing the ore with a hammer to try to separate the asbestos from the rock that it came in. So they're definitely exposed. We have tried when such people approach us, and we ask them first to show that they do have an asbestos related disease, and that was an unquantified expense. So we asked them to get a chest x-ray from a local hospital or a GP, and once, if they can show that there is some damage on their chest x-ray caused by asbestos, then we pay for any subsequent tests that need to happen. So even if it's mesothelioma, we pay for everything. And then on the exposure side, to prove the exposure, we ask them for an affidavit. So, and we have people that we've trained up, and they've trained themselves up over time by being part of the process of taking affidavits, and that should be sufficient proof of the exposure.
Right, thank you.
Okay.
I think maybe let's take an online last question, and just to round up things for the online attendees. We can carry on maybe afterwards. Online.
Well, it's a clear instance of differential access to healthcare, even if it is post-mortem. So the Asbestos Relief Trust has undertaken to fund the removal of heart and lungs in the Kuruman area. We haven't done it in any other area. I don't know how to answer elsewise, but it's a statutory requirement that is unfunded. So that's the essential answer. And then the Asbestos Relief Trust has taken upon itself to pay for the externalized cost, or to externalize the cost from government.
Good, thank you.
Okay.
I think
Thanks.
While we're getting to the end, I think any other. I
There
think
we
we
go.
decide we can carry on with the discussion after we finalize. I really it's a big honor and pleasure for me to thank the two presenters and our host Red Sands here in the Kalahari. It's always nice with the food and everything. Everyone must have a safe journey back, and we're here for the online attendees. We conclude. We appreciate. Make sure that you complete your HPCSA numbers and the online registration. And I think we conclude with the following, looking at the time. Thank you very much.
Thank you, Louis.
Okay, thanks everyone. Louis, and people are saying thank you, Louis. So we're ending the online.
We'll upload our presentation.
Yeah, thanks very much, and we'll upload our presentation.